Welcome to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Garcia. Man, your background is snazzy. How you doing today?
It's super snazzy. This is going to be a good one.
Yeah,
I went all out on this one. AI had some extra time for me.
Yeah, we're really excited. I know you're excited about this next guest, but before we get to our guest, as we always like to do, we give a little shout out to the folks at Mike and the Recovery Shop. Tell us once again why you love them.
So again, big shout out to our sponsors. Again, they're awesome. They're really good for especially us surgeons that do a lot of the complex knee stuff. But ability to have all aftermarket products for patients that really want extra. They constantly are asking for it. I've had a number of surgeons even come up to me during some of these courses that we teach and ask about this. They say, hey, I got my patients asking for stuff, but I don't really know where to send them. I'm kind of tired of going to Amazon, et cetera. So this is a great option. So reach out to Mike B. They're very accommodating. And this is a great thing for us as surgeons to have at our fingertips.
Yeah, and personal experience, just utilizing the Recovery Shop and the great equipment that they have there to help recover throughout my Achilles injuries and things like that. But let's get to our guests. Today on Sports Doc Talk, we're joined by Dr. Travis Maak, the orthopedic sports medicine specialist at the University of Utah, the Utes, head orthopedic team physician for the Utah Jazz. Maybe we'll talk a little bit of NBA because I'm a big sports fan and I have some questions there. All you guys, Stanford, Yale, and obviously hospital.
Pretty poor upbringing. I know really
how do you guys all end up at special surgery? It's great, but selected by the president. He was selected as the president of the NBA Physicians Association for the 2004-2005 25 season. And he's helping shape how we think about keeping high-level athletes performing without sacrificing long-term joint health. Enough with introductions because we have so much to talk about. He's got some cool gear, bunch of stuff. You're going to be all nerded out. We're talking about elbows, knees, and hips. So let's bring him on. Dr. Maak, how are you? Listen, thank you for being here. We really appreciate you being here and taking time to join us today.
No, it's my pleasure. Thanks for having me. Grant, thanks for having me as well. This is a wonderful opportunity.
Awesome. So Travis, will you tell us, everybody, I mean, the listeners already know some of your stuff. They've probably seen your work online for all the things you do. But will you tell the listeners kind of how you got started? I mean, obviously Stanford, Yale, and then HSS, but sort of what kind of spurred you even to go into the field of sports medicine and where you're at now?
Yeah, that's a good question. I didn't actually even think I wanted to become a doctor, to be totally honest with you. When I was growing up, I grew up on a farm in Utah, in really rural Utah. And candidly, I thought I wanted to be a vet, but then I realized animals couldn't talk back to me, and that irritated me. So that's kind of a theme, to be honest. At the end of the day, when things irritate me, I try to fix them, which will be a theme through this whole process. So, ultimately, when I was in high school, I thought it might be fun to be a ski patroller. I wasn't a particularly good skier, and I wanted to get better at that. And I'd heard lots of glory stories about ski patrollers. So I thought this would be a good idea. So back in the day, before lots of regulations, they let volunteer people be ski patrollers on Saturday and Sunday. So I did ski patroller. I was a ski patroller, volunteer ski patrol at Park City, which is right near where I grew up. Not where I lived, mind you. So I'd go there on Sundays and do ski patrol. And there was a crazy experience. I'd done it for about a year and a half, and I got called to the top of a place called McConkey's Bowl, which is in Park City. They now have a lift there, but before you had to hike there. And I got called to go check out an injury that had been reported. And I went down there, and a guy had jumped off this cornice, which was about a 30-foot drop. And he had not, the baskets you have on your poles, Grant, at the bottom. You're a skier, aren't you?
A little bit, but not.
Yeah,
I'm decent.
Yeah, all good. So there's some baskets on the bottom of your poles that kind of stop your ski poles from going too deep in the snow.
Yes.
And so this guy somehow had managed to lose his baskets, and he didn't care. He was still going to get after it. So he hucked this cornice, jumped off it, and somehow in the process of him jumping off this cornice, he lost his ski pole because he didn't have it on his hand, and he impaled himself on his ski pole. Oh. He went literally all the way through. So I didn't know what to do, and I kind of freaked out a little bit, to be honest with you, and just kind of got on my radio and said, I don't know what I'm doing. Please.
Are you on skis or snowmobile? Like, how is this all happening?
Skis. So I'm coming in on skis, trying to ski, and usually get called for somebody gets a little over their skis, literally, and then you got to kind of pick up their stuff, put them back on skis, and get them down. And this was a whole different ball game. So keep in mind, I'm 17 years old, and I come down, and this guy's impaled through his lung with a ski pole. So I totally freaked out, which, by the way, you're not supposed to do. And I call up, and they came down and helped me, and all I remember is being totally helpless. So I never wanted to feel that again. And so at that point, I decided I thought I wanted to learn more and know how to actually help this guy versus feel totally helpless. So then I went to college, kind of bounced around, and never kind of got that I don't want to feel helpless feeling away from me. So that's how I ended up in medicine. And then how to end up in orthopedics, simple. Ultimately, I like fixing things. And in orthopedics, we fix stuff. And I like fixing people who like to fix themselves. And that's sports medicine. So as young, or in my case, old athletes that think we're athletes, even if we're not, and that people want to get back to doing stuff that makes them healthy and have really amazing lifestyles. And so that's how I ended up doing what I'm doing. And I really love all the patients that I treat because I empathize with them. Because at the end of the day, if I can't be active and do sports and do the things I want to do, I'd rather not be around too longer.
That's awesome. So one thing that you're really known for, I mean, we've talked about this at courses together, et cetera, is your preservation. I mean, you do knee, and we haven't worked together with the hip stuff, but what kind of drew you to that? I mean, it's obviously pretty hot space. We'll talk about some of the stuff you're doing there. But why preservation? You could have chosen anything. You could be the multi-leg guy, right? You could be, hip, you could do other things, ACLs all the time. Like what's the reasoning?
Yeah, 100%. So you and I oftentimes commiserate, I think, because we share a similar view on the world, and which is we're sort of masochists, honestly, in the sense that I told Brian Kelly, who's one of my mentors on the hip side, he said, "What do you want to do with your life?" I said, "Well, I really love cartilage, and I really love hip preservation. So I want to do hip scopes and cartilage preservation." He said, "You are going to have a lonely, miserable life." And I said, verbatim, Brian's a man of few words, but he's very sagely. And I said, "Why is that, BK?" Because I called him BK at the time. He said, "Well, cartilage is this unknown black box. We don't know why people get injuries. We don't know what to do with them. We have no idea why stuff works and why it doesn't. And we know everyone has it and it's a big problem, but we don't know how to fix it." And that's pretty much the hip in a nutshell too. So if you want to marry those two, good luck. And I, in my head, I thought to myself, he goes, "But I took the charge because I had the same perspective." And so I said, I really like that, because there's a lot of opportunity there. We can make it better.
I think that's really interesting for the viewers here. Actually, Will, this responds to the podcast we had a month ago. The doctor said the exact same thing about cartilage, and no one could regenerate it, and there's nothing we could do about it. And it's the same scenario in the sense of what Travis is mentioning, right? It's like there's a lot more opportunity. We've already, this, but as we can all do good ACLs, but the ACL hasn't changed a little bit. We have some cool new techniques and little things here, but the cartilage is just exploding. From how do you feel like this, what do you think of in the last, 5-10 years, you think from the cartilage standpoint, either, maybe just on the hip or the knee, you've seen sort of as a more progression, like that black box is no longer a black box in your opinion?
Sure. So again, I use my own folly to lead my wisdom, which I'm not sure I have yet, but I'm working on it. And that is about 12 years ago, I had a patient who, classic Utah, he was snowboarding, totally true story, by the way, off his roof because there'd been a lot of snow. Okay. Yeah, this is real. Okay. So there's a ton of snow that year. So the dude lives in the middle of nowhere. Awesome dude, incredible snowboarder. He goes, "I'm going to huck my roof." So he has his buddy videoing it, of course. So I have the total video. All right. I've shown it a ton of times. So he's snowboarding off his roof and literally drills a tree, like right off his roof, like completely drills it. He dislocates his hip, posterior dislocation, big cam deformity. So hip stuff, FAI, but that wasn't his problem. They reduce him in the ER and then call me because he has a loose body, a retained loose body. So they say, you got to scope his hip, get the loose body out, you're good to go. Okay, fine. So
I'm sorry to interrupt. For those that don't know what loose body means, right? Are we talking about just loose cartilage? What can you explain that to
it's all
listeners that really don't understand it?
No, a heck of a good question. So what's a loose body? The answer is exactly what it says. It's anything that's loose floating around in a joint. So it is a body, i.e. something. It's a kind of a catch-all term, to be honest with you. In this case, it was what I thought anyway, was a piece of cartilage effectively, and a little tiny piece of fleck of bone on it that had kind of cracked off during his dislocation. So you don't want a piece of bone. It's like a rock in your shoe, you know, it kind of bothers you. So you move around your shoe to
That's a good explanation. I like that.
Yeah, you got to take your shoe off, get the rock out.
Yeah.
So that was the game plan. I was going to, you know, put my scope in, take the rock out. That was my plan. So that was all I was planning on doing. So I scoped the guy, I popped the scope in, I'm going to be a hero, right? This is literally a story of every disaster I've ever had. So I put the scope in, I'm going to be a hero, in and out case. And then I look in there and the guy has effectively sheared off, meaning completely taken off, like 2/3 of the cartilage on the top of his hip socket called the acetabulum. It peeled off into the joint. And once again, it's one of those holy crap moments. I kind of felt like I felt back when I was, you know, watching the guy getting impaled by that ski pole. So at this point, I'm the attending trying to do his surgery and fix him, but I didn't know what to do. Because it was all of his cartilage basically, and it was right where he needs it on the top of his socket, where the ball kind of connects the socket. Right, you got to walk on that. So in my head, I'm thinking, well, maybe I'll take it out. Well, that didn't seem like a good idea because it was literally all of his cartilage, and the guy's 22, so that's dooming him to a hip replacement at an early age. Then the other option is, well, whatever, sew it down, glue it down. That doesn't work. So I didn't have any good options. So basically, I said I have no options. Therefore, I'm going to pretend I didn't do anything and go down the ostrich mentality, which is stick my head in the sand and pretend it didn't happen. So that's what I did. So I repaired the labrum, took out the loose body, said, we're good. I really hope you're doing well. Of course, I told him about it like you always do and said, we're going to follow you. So 4 years later, he comes back and says he has hip pain. I'm like, oh my goodness gracious, what could possibly be going on? But at that point, I'd kind of thought about the process because I told you this is a theme in this conversation, which is I really hate stuff that I can't fix. It bothers me. And so during that time, I had asked the question that you asked, Grant, which is, what can you do? What things can we change? How can we help this black box? And the answer is taking people's cartilage that they have already, because frankly, in the hip, we cut away tons of cartilage. My knee replacement, hip replacement colleagues like, yeah, great. You're just accelerating them to come let me replace their hip. Not true, but we do cut out good cartilage sometimes in an area that they don't actually need it. And we call it an ephemeral osteochondroplasty. So I thought, what if we don't have to cut that cartilage out? What if we can save it and collect it and then use that healthy cartilage and put it back where the not healthy cartilage is missing? So at that point, because of him, I'd done a bunch of research on this actually and developed a technique called AMECT, which is autologous autologous matrix enhanced cartilage transplantation. It's a terrible name, by the way. That's why no one uses it.
I mean, we should get to 4 letters. The 5th letter just screws me.
Yeah, it's just absolutely terrible.
Yeah.
You would have had something better. I know you would have. So at that point, I did a ton of research to prove that that cartilage is alive on the femoral head neck junction, which is where the cam is. And turns out it has a time of harvest about 60% viability. And if you combine it with basically extracellular matrix, and then allow it to culture either in vitro or in vivo, and that means out of the body or in the body, it gets up to over 99% chondrocyte viability within 5 to 9 days. So since that time, we proved in our lab with multiple patients who I've harvested from, we can take that cartilage and transplant it at the same time. And at that point, we can actually heal their own cartilage with their own cartilage. So now it's a technique called AutoCart. The Grant knows, and that was the origin of it. Actually, it was a lot harder to harvest back then. There was something called GraftNet that was popularized by a company called Arthrex at the time, and they kind of used it for a different reason. I said, we're just going to suck this stuff out with this GraftNet, and I'll just kind of do it on the back table. So we did it and showed that it worked, and that's been a black box that in many cases we've solved, not with stem cells actually, but rather with the patient's own cartilage and combined with extracellular matrix and growth factors. So that's
is the technique you do similar to the current AutoCart, or is this was the beginning of this scenario?
Yeah, so this was the beginning, actually. So since then, combining it with some cellular matrix, so biocartilage or extracellular matrix, also some biologic factors. So you can combine it with PRP, you can combine it with BMAC, which increases the cellular regenerative capacity. So we've advanced this since then. Again, this was 12 years ago. So now the technique has gotten much better. I told you it was really, really clunky initially when I first did it because I didn't have any technique to tell me how to do it. But now we've got it dialed in, and now we've used it in the knee, we've used it in the hip, and it's a single stage of transplantation using the patient's own cartilage. So that's something super nice that we've done actually, and it's really opened up a lot of opportunity, I think.
And obviously for the listeners to hear this, I think we'll go to the knee in a second because, you know, you and I know the knee better even than the hip stuff. But from the hip standpoint, you know, there really isn't many good options. So to have something that you can use for your own patient, you can do it easily. Because again, it's also harder to do things through the hip because of the access points, right? Versus the knee. And you don't want to, if you go, you know, we can always open the knee, and obviously we don't want to do that if we don't have to, but it's not as hard in my opinion. But if you go open and hip, it's a much different animal. So you're not like, it's not like you can just go and open the hip to do these procedures, right? I mean, it's much more morbid.
That's exactly right.
So that's just something for, and also for listeners to know. I mean, really your options right now, right? The main one, is that one of your main cartilage things you do for the hip?
Yeah, for the same reason you just described, Grant. In order to do anything like, for instance, a bulk cartilage transplant, like an osteochondral allograft, which is using cartilage and bone from another person, transplanting into the hip, that's not just a simple little arthrotomy, which is a little cut you make to open up the hip. You have to completely dislocate the hip. You have to cut bone. You got to do, it's a really, really rough procedure with a hard recovery and a lot of complications. So most of us don't do that very often. This you can do with a scope. You can do it at the same time as treating other stuff. So I would say 98% of my cartilage work in the hip is now done with AutoCart or AMAC.
How long would you tell the patients this would take you now with the, you know, the new systems, right? Because initially it sounds very tedious. Like you do it, you harvest it, you make it. How long would this take someone like you, once you get in there and you realize you have this, to actually do the procedure to implant it?
So a standard hip scope usually takes me, that's using a camera to treat the other stuff in a hip, other than the cartilage, usually takes me somewhere between an hour and 15 and an hour and 45 minutes. This adds 15 minutes.
Oh, that's awesome. So
can you describe?
I was going to ask that.
No, I was just going to say, can you describe a specific type of hip surgery that normally would take X amount of time, and now with this new procedure, you could compare that? I'm talking about recovery time, and
Sure.
then also whether it's not just the short-term recovery, but the long-term recovery differences.
Sure. So prior to this, I had done a few bulk osteochondral allograft transplants to the socket. I did it with my open hips preservation colleagues. I work with some amazing partners. One of them in particular is a guy named Chris Peters, who's very well known in the open hip space. So we did it together. The approach is called a surgical hip dislocation, which is a big morbid procedure. You have to cut what part of the bone, dislocate the hip. It took me about 3 hours to do it with him. And then you have to let the bone heal because you just cut it with a saw. So the recovery, you have to keep them in a brace. You have to keep them on crutches. It takes about three months or so just for them to recover from the open surgery. And again, he's a wizard surgeon. Okay. So I'm pretty sure with other people, it'd take a lot longer. Now with the AMAC or AutoCart technique, it's done through the same 3 poke holes that are about that big that we use a camera to treat the hip anyway. The whole procedure takes me about an hour and 45 minutes with the cartilage if it's an hour and a half normally. We start them toe touch weight bearing. They're still using crutches, but almost no pain for about 4 weeks. They transition by 6 weeks. They're hiking, biking, and swimming. And then we get them back to effectively jogging and running in about 3 months rather than getting off the crutches.
What do you tell them for how long it takes to grow back?
Yeah.
The cartilage?
Yes.
Yeah, so typically speaking with AutoCart or AMAC in the past, we've MRI'd these actually, and generally speaking, you have perfect fill and hydrolite cartilage that's effectively full by 6 months. Realistically, in the lab though, we have mature cartilage that happens within weeks.
Got it.
Because again, you're starting with cartilage.
Well, and also it's autograft. I mean, for the patients listening, that your own tissue always heals faster in many cases than tissue from somebody else.
Correct.
Right.
The other component of this that you mentioned, Grant, and I just highlight this, when you're using cartilage from someone else, which is your point, you got to wait. And you have to wait for someone to have an unfortunate accident. You have to time it. It's really hard. This you can do anytime because you're using that patient's own cartilage.
Yes, Will.
No, I was just going to say that that's life-changing. You know, this is the recovery, and it's getting back to your family. It's getting back to work. It's getting back to your normal day. It's you're not sitting around and your testosterone is shooting down. I mean, I could go on and on just by, you know, this procedure and the recovery time and the quality of life. That itself, just thinking about it is, it's just like I said, is game changing. So it's great to hear.
I want to stay on the hip for a few more minutes, and then we are going to do probably a fair amount of knee conversation with you, because I know you got a lot. This is just the tip of the iceberg with all the stuff that you do.
Yeah, Garcia just wants to talk about knee. He just loves the knee.
I'm trying not to talk about knee, because Travis and I will never get off the conversation. So obviously you have a lot of experience with the NBA, right? You're head team doctor for the Jazz. Where do you, like, from your, again, cartilage and hip stuff, is that part of the algorithm at all with the NBA players? Because it's just barely on the iceberg, or tip of the iceberg right now for knee. And so for the hip, is it a different animal, or are things treated differently in the hip and the NBA?
So interestingly, hip in the NBA, and frankly, hip in all elite athletes, really determines on what position they play. So a lot of cartilage damage, at least for impingement, or FAI, which stands for femoral acetabular impingement, as I know you guys know that already. It's basically the ball banging into the socket when it's not supposed to. That's all that means. That's usually in a deep flexion position. So we see that a lot in guards, not as much in centers, not as much in forwards. And when it happens, a lot of it can be alleviated, frankly, by just changing their strength training routine. So the nice thing about elite athletes, we have a really close access to them. And when they have pain, we can modify stuff really quickly. So the first thing I would say is most of this stuff is preventable, frankly, by just activity modification, changing the way you strength train, that kind of stuff. So candidly, we can avoid a lot of this surgery in elite athletes, and frankly, can probably avoid it in a lot of athletes, period. Hockey goalies are an exception. That's kind of an unfortunately necessary evil. But having said that, to your point, has it gotten people back sooner? Absolutely. Hip preservation. We used to do all this open, actually. Any sort of hip preservation was done open, and the recoveries were abysmal. They got back, but holy smokes, you're talking 1 year, you're talking 9 to 12 months. It's now we get them back to elite athletes. A lot of my US speed skaters they get a lot of impingement because of the positions they're in.
Yes.
And we get them back on the ice within 6 weeks. We get them back in full competition at 4 months, and they're skating at levels they weren't skating before surgery at around 6 months. So that's even without the cartilage. With the cartilage, it really doesn't change that. If anything, it gets them back feeling better, but does not change the timeline.
What's important for the listeners to hear, right? Because you're talking about additional surgeries you do during the time, but it doesn't add more time to your recovery. So it's like, it's synergistic almost. And would you say almost the sense of like, they need it and you're doing it, it might actually improve the overall recovery process, because now they're not having this defect that's causing pain. You've already addressed now all the issues. Less pain during the recovery always makes things easier. Will can attest to this.
Yeah, I'm just thinking about, that one of the famous athletes, and, Ken Griffey Jr. also has some hip issues. The big one is Bo Jackson. And, the things that he never recovered on that tackle on back in 91. And I think, what was that? A vascular, right? Necrosis and some other hip
That's
issues.
not a good one.
I mean, so it ruined his career. He could have been who knows, Hall of Famer in football and baseball. I mean, he was on that trajectory. So it's just, it's amazing. So you talked about the guards. What are the positions that you're seeing some of these hip issues? Because as we mentioned at the top of the show, you're working with the Utes, the Utah football team. What are some of the concerns or some of the positions that you're seeing? And then how are you getting in front of that with the strength training and being part of those conversations?
Yeah, so really any sport that requires deep flexion positions and rotation in those positions. So the worst possible scenario, and it's highlighted because everyone's seen it, is the hockey goalie hockey stop that stops the shot on goal, where they do that flare of their legs, they go out. The butterfly, exactly. So that is the hyperflexion, internal rotation, squatting down deeply. Holy smokes, that's a tough spot. And the hip does not like to do that. So any position that sort of mimics that position, either that extreme or to some degree similar. So and other examples would be baseball catchers, as an example, that deep position. Lacrosse players, soccer players, when they're kicking, not on their kicking leg, but on their non-kicking leg that they rotate on.
Are you seeing it in bodybuilders that are squatting heavy? Are you seeing it in that kind of area?
Interestingly, sometimes, but not as often, because elite bodybuilders do not typically squat with their knees together. They wide squat. So because it gives them a wider base and a more stable base. And what that
sumo squat.
Yeah, so they do a sumo squat to rotate their legs out so they can weight bear more. And frankly, that's protective. So guards are in that deep rotational position. I told you, speed skaters, our Olympic speed skaters on their inside leg when they're down and crouched and curving around, that gets them. So anything, imagine the sports, you talked about football. So in that case, you're talking about your linemen, you're talking about your running backs, not so much your wide receivers because they're standing up and out. So that's kind of what we're talking about.
Gotcha.
Cool.
You asked how we stop it. Quick little comment there. The answer is modifying your strength training regimen. So the amazing thing when I talk to all of my NBA players, the first thing they come in when we draft them and they come out of high school or college is, hey, my hip's been hurting, doc. What's going on? I stretch it and it makes it worse. I'm like, well, how do you stretch it? They're like, well, I got to stretch my external glutes. And I pull it like that. And I bring my knee up and I shove it in my chest and I push really hard. And I'm like, how's that feel? They're like, not good at all, actually. But they tell me I got to stretch my external rotators. I'm like, okay, please don't ever do that again. And then turns out their pain actually goes away. So just commenting and coaching people on positions to avoid can largely eliminate some of these symptoms.
Well, I think the point you made, we've had this many times in this podcast, is that these elite athletes, you're able to get to them faster and more focused, and they get to have doctors like you that sees them right away, and says, this is what you're doing incorrectly. And it's amazing some of the non-operative treatments that we can perform or we can do for the patients, or that how much PT helps when it's done correctly and effectively and more frequently.
Yeah, and you and I have talked a lot, Grant. Like, it's interesting because a lot of people think surgeons want to do surgery. And I would argue that not if they're good ones. Because at the end of the day, surgery makes you different. It may not make you better, and it certainly can make you worse. It can make you better for sure, but I will tell you the people it makes the best are the ones that absolutely need it. And what I mean by that is you try non-surgical management first. You try PT, you try activity modification, you try injections if you need them. And you and I have talked a lot about this. At the end of the day, your best outcomes are in the patients that have absolutely certain indications for the surgery. And I think good surgeons make sure that's the case.
Yeah. I mean, and as what you do, I mean, I think, I want to talk, obviously you guys can already hear who's listening, we're talking about someone that not just takes care of NBA, but is used to, hockey, elite athletes in the cold weather sports, skiing. I've seen some of your presentations on speed skaters, downhill skating, you name it. So you have a lot of experience with different athletes. I know this, I don't want to load this question, but how does treating them different than your average recreational athletes, not from how you care for them in terms of the care you give them or the options you give them, but there is a perspective that's important when you're doing team level or high level professional level athletics. There's seasons that matter, et cetera. Can you maybe listen to the audience who want to hear, they always come in like, I want to be treated like a pro athlete. I'm like, maybe you don't always want to. Depends on how you treat things, right? Everything's a little bit different. But so how do you approach those situations where, maybe they actually need surgery or it's a borderline scenario?
So two things I would say. The first is timing is everything. And elite athletes, the only thing for me that they change is the importance of timing. So you identified it a little bit. So Olympics are actually the hardest, to be honest, because they train for 4 years for 1 month of glory, really like a week of glory. So for them, if they get injured 9 months before their Olympic trial and they've already qualified or they're qualifying, it is a much higher bar because that's 4 years of your life and it's one shot. Whereas, not to say that elite professional athletes aren't elite and important, but they miss a season, not an entire 4-year training period. So at some point, it's a risk-benefit analysis. And that's what I tell all of my patients, whether elite athletes or not. Surgery and timing is a risk-benefit analysis. And I'll give you an example. Even today, I had a high school kid who wants to go, they have a trip planned to Hawaii with their family. He's graduating, he's a senior, he's done playing sports actually, and he tore his ACL. And they want to know, and he has a meniscus tear. And you know this as well as anyone, Grant. He's already a month and a half out from his meniscus tear because it took him that long to figure out he wanted surgery. Now he's coming to see me, and you know as well as I do, he's a young kid with a meniscus tear that needs surgery, and likely you're going to sew it back together. And outcomes are better between 6 and 8 weeks of repair. So this guy needs to get in basically yesterday to get his meniscus prepared to have the best outcome for the rest of his life. And I would argue that's way more important than next year's career or next year's season, if you will. It's for his life. So he asks the question, can I go to my trip in Hawaii in a month and have my surgery after? And his mom's sitting there saying the same thing. Of course, they don't know any better. And what I have to tell him is, well, it's a risk-benefit analysis. You have your Hawaii trip. I totally get it. But the chance of your meniscus healing when you come back 6 weeks from now is going to be less than it is if I fix it in a week. But if I did fix it in a week with your ACL, it's probably not going to be a great Hawaii trip for you, honestly.
Yeah.
So that's a similar balance. Everyone has to make these decisions. The difference with professional athletes, though, is they have a huge armamentarium of resources behind them that maybe sometimes we don't. And that can be both good and bad. So to your point, Grant, do you want to be like them? Well, it depends. So with the resources, sure, count me in. However, they also have a lot of pulls on their requirements to get back sooner. They have a lot of people kind of chirping in their ear, telling them lots of different things, some good, some bad. So sorting through that milieu of confusion can be difficult.
Is it a contract year? You know, are you like,
Yeah.
3 years out of 4 years, you have a player that needs a surgery and, they rush him back because they want to average X amount of money because this might be their last contract and last time to. So I can imagine that's just one scenario. I can imagine all the different scenarios at that professional level.
For the listeners, and this is just diving into the professional athlete level, who do you usually have chirping in the ear? I think they probably were curious. I know you have the agents, you have other you're a very good doctor, but I'm sure a lot of the pros get extra opinions. I know how it works. They fly all over the place and you got to either deal with that conversation or whatever. So what do you see as the outside sources for these pro athletes that cause this situation to be more challenging?
Well, I'll give you an example. Very recent one, actually, and this is in the media, so you can Google it. I'm not telling you anything that's not already out there, but patients of mine, elite athletes that you evaluate, you find things sometimes, and then there have to be press releases about them by regulation through the NBA. The second that press release goes out, everybody has an opinion. You have people that want to weigh in. They want to be the experts. They want to market themselves. And there's a lot of them are critics. Honestly, it's really easy to be a critic, I've learned. It's super easy to throw stones if you have no responsibility for the consequences of the stone. But I've also learned we all live in glass houses, so I never throw stones at the end of the day at anyone. So I will tell you that a lot of these people will write things. They'll chirp on Twitter. They'll say, shouldn't have ever happened, or this was intentional, or for the Jazz they're trying to tank, so they found this one thing that isn't true. And you can imagine as a professional athlete, dude, my knee hurts. Like, I don't want it to hurt. I never asked for this. I don't want surgery. These guys don't want surgery. They're not trying to make these things up. It's just frankly not true. But unfortunately, they have to deal with the perception that they are trying to make this up, that they're getting unnecessary surgery just to not play. And I will tell you, if you sit back for a second, none of you would do that. No one would do that. And they don't either. It's crazy. But the problem is they have to listen to this stuff, right? And they have to get multiple opinions. And of course, when you get multiple opinions, as you know, Grant, because you're a third opinion doc, everyone comes to you for second opinions, and you give them a good one, thankfully. But I will tell you, there are a lot of people that feel the need as a second opinion doc to say something different. Because if you're an elite athlete and someone's like, well, that guy didn't talk to you about this, or that lady didn't talk to you about this, but I look at what I found, all of a sudden you sound smarter. But here's the thing. The goal is not to do that. The goal is to deliver the best care you can, period, irrespective of what other people have said. And that's what I try to do with all my athletes is let them sort through the process. And frankly, I don't have any interest in operating on them or not operating on them. I don't care. I tell all of my elite players of teams that I cover, look, I'm an opinion. I'm happy to take care of you, but I'm also happy to have someone else take care of you and help you sort through the process. Ultimately, my goal is for you to have the best outcome, whatever that looks like for you.
Well, I think it's important for the audience to hear what you just said, because that's a challenge, your second or third opinion. You want to be respectful of the first opinion, second opinion, because if you start, first off, you think it may make you feel better, but the people are going to come back and they're going to talk to the other doctor sometimes and be like, this guy said this, you were crazy. Like, it's just not a good idea, as you keep saying. Like, you don't get away with that. We have that. I know of many people I can talk off the top of my head and from the city that I have heard about those scenarios. So you just want to be careful, right? And the other thing is, it does a disservice to the patient, as you're saying, whether it's an elite athlete or a regular athlete or anybody off the street, because then they confuse them. And when you confuse them, then they can't make their regular decision. Your whole goal is not to make yourself smarter than the person that saw them previously or pretend that you're smarter. It's to give them the opinion, like you said, completely unbiased. And many times I tell them that actually the best opinions are when like three people say the same thing. Like I sent someone for another opinion today, and I was like, we're doing a big knee surgery. And I say, why don't you get another opinion? And I hope it's similar, because that way at least you won't feel like we're totally out of line, because it becomes really challenging to make the right decision, right? If you're a patient.
It's fascinating that the other flip side of the coin is also equally good, I will tell you. And the reason I say that, so when I was first starting in the NBA, and it was 12 years ago, I've done this for a long time now. So the first guy I operated on, I'd literally barely started taking care of the team. And he had an injury in his shoulder. And I told him what I thought was going on. And then he flew around and got 4 other opinions, okay, in addition, which they're totally fine. That's pretty standard, actually, for the NBA. The fascinating thing, every single one of those opinions, and these are all well-known, very good doctors that I respect highly, said something different. Every single one of them. So by the time we were done, he had 5 opinions from 5 doctors, all that said something similar, but also different. So at the end of the day, the good news was I could do whatever I wanted because someone had said it was right. Like, pick your poison. It was right. I'm like, well, that's good news. So
well, that's a very rarity that you got to have a dealer's choice jokers.
Yeah, it was fascinating. But
oh my God.
Can you talk about that a little bit? How did you become the NBA Physician Association, like the president? Like, how did that come about? I'm just curious.
That was dumb luck, to be totally honest with you. I mean, honestly, so
you guys can see it already. Everyone's listening. They're like, no way that guy was lucky to get it.
No, it's true. So the truth is, I'd done it for a long time. I was one of the old guys in the room. And I think, for better or for worse, when I get irritated by stuff, I usually raise my hand and say something. And that's both good and bad, okay? Because sometimes it's not anything anyone wants to hear. So I think in the room, there were a few things that really bothered me. And so in the process of having conversations and asking questions, I think the questions that I asked echoed what a lot of people in the room, the other NBA physicians, were thinking. And so I think that's really what kind of made them. And I also was involved. I chaired the NBA research committee for a while. So I kind of understood how the inner workings of the NBA with the NBA teams worked. So it was a combination of those things. And frankly, just asking the questions that I think everyone else maybe was thinking, but didn't want to ask because they were a little irritating.
Yeah.
On the NBA, I know obviously you're pretty involved. Do you know, I mean, obviously there's a trend right now. I mean, what's your trend, or how do you guys work on injury prevention and working on athletes' health? I mean, obviously it's important. We talk about this all the time, nutrition, recovery systems, things like that. But what are you guys doing to advance that? Because obviously every time some player gets injured, it's a lot of money lost for the Utah Jazz.
Yeah.
Or any of those players you take care of. It's a player for the player can lose money from their contract or not get re-signed. And as you guys, you don't get the output, right? You don't get a playoff or you don't get a championship.
Right. High risk. So here's what I'll tell you. When I'm asked, and the Jazz organization is phenomenal. I'm blessed to be able to take care of such an incredibly confident and honestly supportive organization. I think some docs aren't quite so lucky, but I do consider myself very lucky. So in that capacity, they really do listen to me. But sometimes they'll say, "Hey, doc, how do we make it so our players never get hurt?" And I said, that's like, I have a total.
That's a very good, that's a legitimate question though.
Yeah.
That is like, it's a business.
I have an absolute certain answer for them every time. And the answer is set them on the bench, like 100%.
Yeah.
Like, don't ever play them and they will never get hurt. The problem is that's not reality. So I hearken back to one of our elite alpine skiers who is an Olympic gold medalist. And she sat in a meeting. It was a huge conference and she was the keynote speaker. It really hit me hard. This was years ago. And she said, this is called the Consortium for Illness and Injury Prevention for the US OPC, which is United States Olympic and Paralympic Committee. She said, the first thing I'm going to tell you is that term injury prevention is offensive. And I said, wow. And it was like a pin drop. You could hear a pin drop in this place because it was literally the conference title, okay, for the whole
thing. The conference side.
And everyone's looking at each other like, oh boy, where are we going from here? And she said, it's not that you're not wrong, or it's not that you're wrong. It's just that injury prevention is a fallacy because any athlete that puts skis on, that straps on shoes and goes out and plays a sport is going to get hurt. It is fundamental to what we do because you put your body and you push it to the brink. And sometimes you cross the brink and you get hurt. So when you say there's something like injury prevention, then the athlete feels like somehow it's our fault we got hurt. and we should have been able to prevent it. She said, here's what I'd suggest. You should call it the Consortium of Illness and Injury Mitigation, because that's really all we're doing is trying to reduce but not eliminate the risk. And it was really interesting to hear her phrase it that way, because she's totally right. At the end of the day, that's what we do. So how do I apply that to the NBA? The answer is lots and lots of biomechanical engineers that are way smarter than I am. We do force plate analyses. We do 3D motion capture. We watch them move all the time. We check their electrolytes. We make sure their labs, vitamin D, calcium, all of this stuff is constantly monitored to really push their bodies safely to the brink without crossing it. Because at that level, just like Olympics, when you're talking about a split second or even a millisecond different, that push is the difference between winning and losing. But you push too far, and we've seen it in the last Winter Olympics, then you get injured, and that brink is the end. So that is a really narrow gap, but there are lots of things that we explore to try to push them safely. All the other thing is a huge credit to the NBA league. They have developed a huge database that's a curated database. So anytime an athlete gets hurt, it's very specifically inputted into the NBA EMR. It's curated. We have an incredible stat system called IQVIA that constantly evaluates it. And we get updates quarterly on here are the injuries. We see an uptick in here. This last one was Achilles tendon tears. The second Achilles, there were a lot of guys that tore their Achilles. Everyone heard about it. Holy crap. Like, what's going on? Right? So I can tell you the first thing that happened, we all sat down and within a week developed an elite expert consortium on Achilles tendon tears to say, we had Bob Anderson, we had Marty O'Malley, we had a lot of folks in the room, myself included, although they were the experts, not me, to kind of talk about this, to say, look, let's look at the data, let's look at the analytics, let's take the video motion capture of every game, analyzing loads. Is it overloading them? And people talk about load management. It's real, okay? It's not like trying to stop players from playing. You push them to the brink. And you don't want to push them past the brink because then they tear something. I know everyone wants to watch their favorite player, but you don't want to watch them get hurt. So pushing to that brink is the game.
Got it. Well, Will, this is super interesting. Sorry, Will, ask your question. I wanted to make
No,
sure
I kind of wanted to stay with the NBA a little bit. Obviously, on February 3rd, the Jazz traded for Jaren Jackson. 2 weeks later, you're working on him and operating on him. So it's two questions, really.
I don't even know if he wants to.
I'll say what I can. I'll say.
Yeah.
Well, no,
he
read the news article. It's in the published news article.
Yeah.
What
So
he wants. What do you want to ask him? Will ask him.
Well, one, the surgery, right? Because this, Jaren Jackson is a big time NBA player, right? So just the type of surgery, and then also I'm curious, and you answer whatever you can. Is management and general managers having these conversations knowing that maybe a player is already injured before they're making a trade, this huge investment is coming over, and then you're saying, yes, I've looked at his whatever it is, and I recommend this trade. I think we're going to get him going. He's going to be an incredible part of this Utah Jazz in the 2026-2027 season.
So I'll answer this in a somewhat of a vague, nebulous answer without directly applying it to Jaren Jackson Jr. So in general, this is how it works. So if a player is getting drafted, or in this case, traded, especially a high value player, but I will tell you any player by definition is high value. He's really expensive though, because he's an incredible player, obviously, as you know.
Top players in the NBA.
100%. And an amazing human too, by the way. So what I will say, the way it works, the draft gets made, the teams agree, and then they say, and this is true for all trades, okay? So the trades get made, they say, okay, fine. Both teams agree, and then they fly the players in, and we evaluate them, and they give us all the information. The team doctors and the teams are very open about what injuries they've had. We review and get access to their EMR, and it's very selective. So I only get granted access for 24 hours or 48 hours, depending on the time, to his EMR. And at that point, I get to review all of his injury history, all of the notes, everything, just like you're seeing a patient, right? So you review produce. It's the same story. So I see the images, I read the reviews, I see the doctor's notes, etc. Then they fly him in and I examine him, and the players are really open about everything. People think they hide stuff. They don't hide stuff. It's not in their best interest to do so. They want to be healthy too. So they actually like the process, I think. I've never actually asked them, but I think they do, in the sense that they get lots of doctors always taking care of them. I'm sure it gets onerous at times, but for the most part, they like the new opinions and new views. So they're very open. They say, look, I've had this surgery, or I have that surgery, I have this thing that's kind of sore, that thing that's sore. This is how I treat it. Same like a patient when you go into the doctor's office, right? Same story. So at that point, we evaluate them. And if they've had stuff that we want to make sure looks okay, or if they're having soreness, then we get a full battery workup, just like you would a patient. So we get x-rays, we get MRIs, we evaluate all of them. And then once that's done, then we say, yes, they pass the medical physical or they fail the medical physical. So it's very rare to fail a medical physical. Okay. So that is something where, to be honest with you, I don't think I've ever failed anyone, honestly, in a trade. Now, I've failed people in the draft, but I have not failed people in trade. So fail means you physically, you're like, from a physician standpoint, believe that their participation in the sport of basketball or a sport is dangerous to their health. They cannot practice or play safely. Okay. So that's kind of where this, and that came into the conversation in the last Olympics, as you probably know. So with Jaren Jackson Jr., that was the conversation. We knew everything in advance. And then you have a conversation, and that includes the patient or the player, and they're the same thing here. And then you have a conversation about what's best for them and what they want to do. And then you get with the team, and ultimately it's the same principles. And this is what people don't understand, that it's not any different for a trade than it is a patient, which is, can you play with this? In his case, do we have to take this thing out? What are the risks with taking it out? What are the benefits with taking it out? Like, does it hurt you? Does it not? It's literally the same thing as taking care of a patient. It's just the stakes are maybe a little bit higher, but I would argue not that much higher, because I don't want my knee to get messed up either.
Yeah. No, that's perfect. On a new note, because I want to show this part, can we pull up the slides? So we talked a lot about hip. I'm not going to get as much time with you on the knee, which is sad for me, but we'll figure it out. But also, you talked about cartilage from somebody else. Obviously, you have a wait list. That is a knee. Yes, we finally got there. But cartilage transplants, I do a lot of them. You do a ton of them. I've seen your stuff on it. But one thing that's really cool is, like, you talk about, you've already done a lot of innovations. I mean, you talked about the thing that, AMSET, I can't even say it right.
Dude. I told you.
AMIC.
Just call it AutoCart. That's really what it's called now.
AutoCart, right? Like a huge jump right forward with cartilage. You're now trying to do another cutting edge technology for cartilage transplants, right? Because while AutoCart's great for many scenarios, especially hip or some smaller lesions in the knee, the cartilage transplants is still a high workhorse for some of us cartilage surgeons. So review this, briefly, obviously, what jumped you to this, and maybe go to the next slide, Will. And so for the sake of time, he can kind of go over some stuff that he's discussed.
Yeah. So
tell us a little bit about this.
Yeah. So bottom line, as you know, Grant, because you and I do a lot of this, bulk osteochondral allograft transplant. So that's taking cartilage from a donor and living cartilage, just like a transplant, and transplanting into a person who we talked about before has a hole in their cartilage and pain from it, is an amazing thing. So it's a true living transplant. And cartilage, for the listeners that we may not know, is something we call immunoprivileged, meaning we talked about AutoCart. That's taking the patient's own cartilage. That's fine because it's your own. But this is taking someone else's cartilage and their bone and transplanting it into a person who needs it. So interestingly, the cartilage, I can take my cartilage, Grant, and put it in you. Oh, you're younger and healthier, so I want yours instead. And that's totally fine. But the problem is, and bone actually heals really well. So taking cartilage and bone and transplanting that is incredible. Now, you can't transplant the bone marrow, so we got to be a little careful with that. And there are ways to get around it. But one of the downsides of osteochondral allograft transplant is that the curvature has to fit. So what does that mean? Well, you can't put a car tire on a truck. It doesn't work because they're different sizes. They're both tires, but it doesn't fit. So this is not like a transplant where you have to match the heart and all the cells and all that fancy stuff that I'm not smart enough to understand. But instead, you have to match the curve. So you have to get a person's own bone and cartilage and match it with someone else's own bone and cartilage. Now, there are places that that's easier, but there are places that's really hard. So one of the examples as shown here is the trochlea. So that's the groove that the kneecap or patella runs in. It's got a unique curvature that's really hard to match. And then you do your best effort, and then surgically it's really hard, because if you transplant it incorrectly and you pop it in, it's a one-shot deal. If you get it wrong, that ship is cooked. So that's it. You don't have another chance. You say, I'll get it better next time. Nothing else I can do. So I found it very complicated and hard. I told you, I'm not very good at stuff, and I find problems and I like to fix them. So I wanted something instrumentation that could make me a better surgeon, which is not that hard to do. That's the first thing. The second thing is, I had a patient, I told you, I don't like things that make me angry that I can't fix. And this was one of them. I had a patient with a cartilage defect on the top of their shin bone called the tibial plateau. And that's what's shown
there on the right, guys.
Yeah. So it's crazy, because there it looks easy to transplant, but the problem is the femur's in the way. So the other side of the knee, so you can't get there. And you literally cannot, or at least it's really hard, arguably almost impossible, to put a cartilage and bone transplant into that place. But I really wanted to do it because they do so well, especially when the bone is bad. You got to fix the bone too. So I got really frustrated watching these patients come through my clinic and saying, there's nothing I can do for you. And orthopedic surgeons, in classic fashion, when we don't have an option, then we say to ourselves, ostrich, put your head in the sand. It doesn't exist. And we say, duh, you don't have to treat it anyway. It's going to be fine. But I would argue, if it's not fine on the femur, why is it fine on the tibia? The answer is because you can't get to it. So you just convince yourself it's okay. So good news, we can get there now, because I got really angry. And some people much smarter than I am helped me, biomechanic engineers, Zach Evans, Wade Fallon. They helped me out at the University of Utah to develop instruments that allow us to get there now. So this is the ChondroMatch family. It's a comprehensive osteochondral repair transplant system. ChondroMatch Standard allows you to do a very fast and easy transplantation technique using this amazing little guide here.
He's going to show it.
Oh yeah, it's got little 4 feet. It can transplant directly on it. I would even say, you see this is an ankle. It's a talus. It's super hard. But look at that thing. It lines up perfectly. All you have to do is take the 4 feet, you pop it on. No matter where you pop it, it finds its spot. And the same thing in the knee. It's the same story. In the trochlea, it can find its spot. But holy smokes, this is small. What if it's a really big defect? So this is the trochlea, right? There's a big hole here. And if you want to match that hole, that is tough. So if you come in with a circular piece, look at that. It doesn't fit. You got to kind of guess, right? And this is what you and I do right now, Grant. We guess. We put this in here. And thankfully for you, you're a really good surgeon. So your guess is as good as anybody's. It's very educated. But for me, I'm not so good at guessing. So what do? Well, I come up with something that makes me better. And that's this guy. It was designed.
This is the coolest thing I've ever seen, by the way.
Yeah, so it came up from a game I used to play when I was a kid. My parents got me this hand where you stick your hand on the nails, and it made an imprint of your hand. All good things have already been invented for kids, just so you know. So at the end of the day, better nails was the idea for this. So I said, well, if it can take an imprint of my hand, it can take an imprint of a trochlea. So good news, that's exactly what this does. These little bed of nails push down, they're a little spring loaded, and no matter what I do, they stay right where they're supposed to be. And then you kind of take the imprint of the patient. In this case, we'll drop it down here. And then you screw this thing down like that. And next thing you know, you've got a bed of nails. And look at this. You put it here, it doesn't fit. But look at this. You just screw it home, and it sits right where it's supposed to be. It sits right where it is. And then
we'll put all of us up on the screen while he's talking. So for all the viewers that understand that this, they don't, if you're an orthopedic surgeon watching this, which is what a lot of people are that watch this show, they're going to geek out when they see this because they don't understand how hard this can be. Yep. So he just basically used a simple toy and figured out a way to make a very hard portion of the surgery. This is the trochleas, in my opinion, are the hardest of all the major transplants. And then he also found a way to fix the plateau. And you guys may or may not, the reason I had him talk about some of this, and we can talk about it now, is there was a press release because you were the first one in the country to use that technique on the reversed tibial plateau, which is really good. So I think what's interesting for the listeners is that not only are you talking about all the cool stuff you're doing and giving the updates and helping out the NBA players with non-surgical treatments, you're finding ways to innovate already complicated procedures, or you're taking things to the next level so that so the surgeons, the regular population of surgeons, can take care of patients better, which is really awesome.
I'm going to geek out one more, Grant. The reason this all came full circle, and the person, the genius behind all this is not me, actually. In addition to the two people I mentioned before, it's Charlie Saltzman. So he's a mentor to me. He was my chairman before. He's a foot and ankle surgeon that's since retired. He and I did a lot of osteochondral allograft transplants to the talus. And holy smokes, those are hard. The reason is they sit right here on the corner. So now, Grant, you'll get this because you do this a lot. Now imagine taking a transplant like this. Okay, you have to come at it through a malleolar osteotomy like that. So now you have an angle like this. You also have a translation this way and a translation that way. So you have an X, Y, and Z axis that you have to match. And then you put your graft in this way because you can't come perpendicular because.
So you got it. You're putting it with an edge, and so it's not a contained. You're basically trying to put a plug that's. Oh my gosh! So that's why that new thing is going to be better.
On the shoulder, okay, right here.
Will, this is like shooting a bullseye from like 1,000 yards out.
So check this out, man. So here we come in. You get your angle right here. You don't know what it is, but guess what? That's your answer. And then you come into the donor, you lock it in, you have your angle. It's dummy proof, and I like to call it Maak proof. So you come in like this, pop it in, you've got your graft. No longer do I have to sweat bullets, because Charlie would sit over me with his glasses like this. Is it going to be perfect? I'm like, I don't know, sir. I mean, I sure am going to try. And that's how it went. So that was the design.
So he scared you into doing this. I like
oh my
that.
Goodness, terrified, because he was my chairman. And I was like 3 years into practice. I was terrified. So we got pretty good at it. He's actually been subsequently an incredible mentor to me and helped me design this whole thing. And the impetus behind it, he was super supportive. The whole, he's like, we got to do this is better. Like, you just all stress for this, Travis. We got to do better than this. So he, in concert with the Orthopedic Innovation Center, the OIC, was a genius behind this. So we're super excited about getting out there to everybody. And Grant, you're on the list, buddy. We're going to send you some sets pretty soon.
Dude, I am so excited.
Nice.
Travis, as I said, we were going to try to go 45. We're at 56 minutes. We have to cut off at 1 hour or social media will be mad with us.
No,
so
good.
We're going to let you go. Will, I know you got a billion questions for Travis.
We need 2 more hours.
You're
I want to talk
overwhelmed.
NBA, hockey.
This is a 6-part series, everyone.
Yeah. Let's talk. I want to get into the Lindsey Vonn and the injuries and the mindset of the pro athlete. And we got too much stuff.
God.
We just want to thank
Travis.
everyone.
One second. Where do you see the future for some of these things? And I mean, you already showed the future right there. I mean, this isn't even out. Like, you're the only one. That's the first time I've ever seen this. This is incredible.
Yep.
So where do you see the future for some of the cartilage stuff that you're doing? Again, as briefly as possible. And then we'll finish up any questions.
The future is in biologics, in my opinion. So ultimately, it's going to be taking stem cells, and I do this in my lab as well. We can take stem cells from juvenile chondrocytes from their little tiny finger, the 6th finger that we throw away. You may remember, Grant, kids that are born with 6 fingers, you cut the 6th finger off. That is great cartilage. I can take it to my lab right now. I can take juvenile chondrocyte implantation stem cell sheets and put them down. That's where it's going to come. So at the end of the day, a lot of this stuff is, I mean, maybe in my lifetime, I don't know, hopefully, but down the road, a lot of this stuff is not available in Europe. It's not available in the Asian countries, the osteochondral allograft transplants. In the future, we're going to be able to create this stuff, not from people who had unfortunate accidents, but synthesize it in our lab in bulk fashion and have it ready to go in the OR. That's the future. We're almost there.
Will, anything closing?
No, we're just going to thank you, Dr. Maak. Thank you so much for spending time with us. Check us out, sportsdoctalk.com, for great interviews, transcripts, and so much more. Once again, Dr. Garcia, another great one. Say goodbye, Dr. Garcia.
Appreciate you both. Thank you so much.
Take care. Bye.